There's 20 million heart attacks that occur every year in the Western countries. And this dwarfs the next most common cause of death, which is cancer. And that's what is surprising to me, is that when someone gets a diagnosis of any sort of cancer, heaven and earth is moved to treat that patient. But if you have high cholesterol, and which is as dangerous as having a cancer, people take it kind of lackadaisically. They don't feel it's as important, although it does kill much more people. Heart disease kills more people every year than all of the cancers combined. So that's why it's so important.
Hello and welcome back to the Vibrant Wellness Podcast. I'm your host, Dr. Emmie Brown, joined by Melissa Gentile. Today, we have the distinct honor of speaking with a true pioneer in integrative cardiology, Dr. Giovanni Campanile. Dr. Campanile is a Harvard-trained cardiologist with over 2 decades of experience in both clinical and preventive cardiology. Throughout his illustrious career, Dr. Campanile has seamlessly blended traditional cardiology with functional and holistic practices. His commitment to patient-centered care emphasizes nutrition and lifestyle factors as the cornerstones of heart health, focusing on prevention, disease reversal, and the promotion of healthy lifespan. Join us today as we delve into Dr. Campanile's innovative approach to cardiovascular health, exploring how integrative and functional medicine can revolutionize heart care and overall well-being. Thank you so much for being here, Dr. Campanile.
Well, Emmie, thank you. It's my pleasure, Melissa. I'm very excited to do this. I think Vibrant is a very innovative company, and we think that getting the labs out is in functional medicine. The lab part of things is such a fundamental part of what we do that I think that your company does great work, and so I'm a big fan.
Thank you so much for that. And I want to get into how you like to use labs overall in general, the functional medicine labs, the imaging strategies we're looking at now. And before we jump into that, I just wanted to throw out there, everyone's aware of heart disease and it's a big deal. It's the number one killer, of course. And I just wanted to pull a couple CDC stats. This one in particular was striking to me. They report about 1 in 20 adults aged 20 and older have coronary artery disease. That's about 5%. And 20 and older. So we're not thinking about young people typically when it comes to heart disease, I think, as far as the public goes. But that was quite striking to me. And then I think more people are aware of the frequency of heart attacks. In the United States, someone has a heart attack every 40 seconds. It's just staggering.
It is staggering.
Mm-hmm. So before we get into your practice, I would love to know, you're coming from a allopathic background. What inspired you to blend traditional cardiology with functional medicine, Doc?
Well, specifically because I did come from an allopathic background, I was an interventional cardiologist where I put in thousands of stents, and I realized into this practice of putting in stents that there was a baseline fundamental reason why people were getting disease, and it wasn't really being addressed by interventional cardiology. I think interventional cardiology is life-saving. It's I did a lot of heart attack patients. They'd come in, we do a stent, and basically save their life. So it's magical. It's great. I don't want to belittle allopathic medicine, but that doesn't take care of anything. It doesn't take care of the fundamental reasons why people are getting disease. So I consider myself now a reformed interventional cardiologist. My practice is focused on prevention and reversal of heart disease.
And how does your new approach differ from conventional approaches?
Well, the main difference is we in functional and integrative cardiology, what we try to do is really find out what is the underlying cause. Because in traditional medicine, they look at the traditional risk factors for heart disease, like high blood pressure, smoking, having high cholesterol, these things. But there are many non-traditional risk factors, like hormones, the lack of exercise, your diet, external toxins. There's a recent study coming out of Italy showing that plaque that was removed from the neck arteries during a carotid endarterectomy, 100% of them had plastic, microplastics,
Yeah, I
nanoplastics.
saw that one.
I saw that too,
so,
yeah.
There's things that are in our control and things that are not in our control, but understanding why someone develops high cholesterol or the subsequent effects of high cholesterol is very important. And then trying to reverse those underlying causes by first taking a lifestyle approach, really getting patients to eat better, exercise better, sleep better, stress better, love better, connect with others better. All these things are fundamentally important to getting the risk down, because as Americans, as you mentioned, the burden of disease is incredible. We're one of the major Western countries. There's 20 million heart attacks that occur every year in the Western countries. And this dwarfs the next most common cause of death, which is cancer. And that's what is surprising to me, is that when someone gets a diagnosis of any sort of cancer, heaven and earth is moved to treat that patient.
Right.
Nothing is left untouched. But if you have high cholesterol, and which is as dangerous as having a cancer, people take it kind of lackadaisically. They don't feel it's as important, although it does kill much more people. Heart disease kills more people every year than all of the cancers combined. So that's why it's so important.
And you mentioned some traditional risk factors, including toxins, and I want to talk about how you like to best screen for toxin burden, Dr. Campanile. But what other risk factors? What does your intake look like? Are you looking at alcohol? Are you getting as specific as how often people are exercising? What kind of exercise, strength versus cardio? How specific is your intake?
Very specific, because we now know that different types of exercises actually help in different ways. For instance, if you look at the heart as we age, our heart tends to get stiff and shrinks. And you can offset that by specific types of exercise. Like if you do high intensity exercise, that offsets the aging process by relaxing the heart and actually keeping the heart a certain size. And so I always recommend to my patients to try to do a variety of exercises, including aerobic exercise, which is good for your VO2 max, which is your body's ability to extract oxygen from the body. And 1 to 3 times a week, try to do a high intensity interval training. And we recommend all different types of this. There's different ways of doing it. If you do it always the same way, it gets kind of boring. But if you do Tabatas, or if you do 10 by 1s, where you go all out for 1 minute, slow for 1 minute, all out for 10, or Norwegian 4x4s, all out for 4 minutes, reduce for 3 minutes, do that. It takes about 20 minutes and 3 times a week. Super helpful, and then diet. We know that, in the Ornish diet, we used to put every single patient on a 10% fat vegetarian diet. And most people's responded to that pretty well, but not everybody. And so this goes to show how we are individualized. We look at certain biomarkers in our lab tests, and some of these that Vibrant does, to see if patients are either producing cholesterol or hyperabsorbing cholesterol. And if you're a hyperabsorber, the diet may be different if you're only producing cholesterol. So it's, very personal. We always talk about personalized medicine, but this really needs to be personalized, because everyone is different on how they respond to different interventions.
Right. And before we get past diet, it's such a huge topic, and we could dedicate a whole episode to just diet and heart health and disease. I think it's still controversial as far as red meat, even pastured, grass-fed, grass-finished red meat, and even, with established cardiovascular disease. What's your take on it? Because I think the conversation changes when we're talking about prevention with somebody who has, they've had advanced lipid markers and they're within normal limits, or maybe they're even optimal. Do your thoughts change on high quality red meat with established heart disease?
Well, I I'm a big proponent of a Mediterranean style diet. And what that means is it's a sensible diet where you eat everything, but you don't eat saturated fats or carbohydrates to any major degree. I think
In
both of them,
excess, yeah.
for different reasons, have a different negative effect if consumed in high quantities. Now, if consumed in reasonable quantities and you're eating high quality meats, high quality poultry, and especially high quality fish, then that is health promoting. We see this it's very difficult to do nutritional studies, but if you look at population studies around the world, people that do this and eat this way tend to live long and well, have a better health span. And
looking at the blue
carbohydrates
zones,
are very important. A lot of people, I get a lot of comments from people saying, it's really, don't worry about the saturated fats. Now we know carbohydrates are bad for you, but they're both bad in high quantities. You can't just say, you can't throw the baby out with the bathwater. You have to, the carbohydrate side of things is related to how our insulin affects our cells, how our blood sugar affects our arteries. And so if you're eating too many carbohydrates to the level that your hemoglobin A1C goes up, or your fasting insulin goes up, or your glucose tolerance test is abnormal, then you're creating metabolic issues, which affects arteries and affects lipids. We look at certain things about lipids. For instance, when we look at advanced lipid markers, we look at particle sizes, very important. If the LDL, or what we used to call the bad cholesterol, is small, and you have a lot of these small particles, that's not a good thing, because then the likelihood of those small particles getting in between the cells in your arteries goes up, and then that causes the initial nidus for atherosclerosis. So that's what we really want to prevent, is that atherosclerosis. And as you mentioned, this is something that starts very early in life. There's some studies that show fetal ultrasounds showing a fetus with atherosclerosis. And then studies have been shown, like in the Vietnam War, and autopsy studies of young people that die in automobile accidents, that by about age 18, 20, most Americans already have fatty streaks. In fact, I think almost 100% of the unfortunate young men that died in the Vietnam War, and this is years ago, almost 100% had fatty streaks. And they were 18, 20, 20 years old. These are young boys. So, what happens is that this process starts very early in life and then progresses slowly over years and decades until you get into your 50s and 60s. And that's when you start getting heart attacks. And we really want to prevent that as best we can, because the first sign of a heart attack can be cardiac sudden death. In fact, more in women than in men. About 50 to 60% of the first sign of a heart attack in a woman is cardiac sudden death, and about 50% in men. That number is getting a little bit better, but it's still a substantial number of people, when they get their first heart attack, just don't survive. So that's why it's so critically important to know about it, prevent it, and know about, again, the risk factors. And again, the atypical risk factors can be other things like depression. Depression is a major risk factor. Autoimmune disease. That's why we do a lot of these panels that Vibrant also does, to look for autoimmunity. Autoimmunity leads to inflammation, and inflammation is a huge risk factor for heart disease. In fact, women and men, but women more than men, if they have high lipids and they have high cholesterol, high inflammatory markers, they're at double the risk. So it's very important to know that. And then again, in functional medicine and functional cardiology, then you go to the why is the person inflamed? Do they have gut issues? Do they have joint issues? Do they have other things? Is their diet poor? It's very important to know this. Our bodies are very resilient. We get sick cell by cell, and we get better cell by cell. So it's a slow process both directions. But there was a study looking at egg McMuffins, and in fact, they gave people one egg McMuffin, and they measured inflammatory markers, specifically nuclear factor kappa B, which is a huge inflammatory marker. It causes cancer, and the interesting thing about that study is that by eating one of these egg McMuffins, that that nuclear factor kappa B went up and stayed up for 2 to 4 hours after eating it. So, again, if you eat one of these things once a month, you can tolerate it. But if this is your breakfast every day, that's a problem, because then these inflammatory markers go up repeatedly, and that's what really leads to disease. It's this repeated insults that cause serious disease over time. That's why Americans who eat a lot of processed food and ultra processed foods, we have a big problem with this, because our obesity rates are high, and obesity is very much related to inflammation.
When you have a patient coming in, maybe their level of LDL small particles is out of range, it's starting to creep up. What are some of the therapies or kind of lifestyle prescriptions that you're using with that patient to help see those back in range?
Well, first of all, one of the things that came to light in the recent past is that there's apolipoprotein B, which is an easy way to determine someone's risk, because when I was in training, we never even looked at apolipoprotein B or other factors like lipoprotein small a, which we'll talk about. But the apolipoprotein B is probably the best way. If you're going to look at one thing, you look at that number, because that number, every particle that is going to cause damage to your arteries has an apolipoprotein B. And you don't even have to look at LDL particle numbers, really, because as the particle numbers go up, every particle has an ApoB on it. So that ApoB is going to be higher, the higher your particle number. And if they're small and a lot of particles, same thing, every particle. So apolipoprotein B is a convenient way to really look at your risk. We look at everything because there's residual risk. And we want to know if the ApoB is down, if we have the residual risk down, to really lower someone's risk as best we possibly can. And, we usually start out with lifestyle. We look at the way they eat. And if they're eating incorrectly, in our opinion, like if they're eating a lot of fast food, a lot of ultra processed foods, we get rid of that. A lot of carbohydrates, we get rid of that. So we generally put people on, I don't even want to call it a Mediterranean diet, because there's some baggage associated with that, but a sensible diet where you eat a lot of plants, all the different color plants, because we don't even know what are in these plants that help people. But what we do know is that in populations that eat all the different color plants, they're getting all those phytonutrients, the polyphenols, the flavonoids, all of these things help us and help our arteries. And then, if you like red meat, good quality red meat, usually the rule of thumb is red meat 2 or 3 times a month, poultry 2 times a week, and eggs. The data about eggs go back and forth, and it drives us crazy. But I think eggs are good for you. They're a perfect protein food. So we usually recommend 4 yolks a week, egg whites all you want, and fish. That's number one. And then we look at their exercise. They're moving. They have to be moving regularly. Movement is very important. We now know that the very first thing that happens before you even get atherosclerosis is the endothelium. The endothelium is a 1-cell thick layer of cells on the inside lining of the arteries, and that is very important for the flexibility of the artery. And so when that endothelium gets damaged, and now we know even more, there's these hairy-like structures that go through the endothelium that's called the glycocalyx. And so the glycocalyx and the endothelium it's basically the barrier that protects the arteries, and exercise really helps those barriers. And that's why we recommend exercise. You get a lot of bang for your buck with exercise. And so nutrition, exercise, and then sleeping properly. There's unfortunately, we have a lot of bad epidemics, simultaneous epidemics going on in America. Obesity, and then sleep deprivation is another one. And this is also very much related to heart disease. So we try to get our patients to sleep better, and then reduce their stress.
You just talked a lot about diet, but I want to hear what your opinion is on fasting, and if this is something that you're integrating into a lot of the protocols that you prescribe. What's your stance on it?
Yeah, I think fasting is very helpful. I know Dr. Volto Longo is somebody who I know well, and he's the person that studied this in San Francisco quite well. He's come up with this fasting mimicking diet and the effect it has on the body. And so, I think the reason why fasting is so effective is that, genetically our bodies are geared up for fasting. We have a lot of good effects in our body from temporary fasting. And we don't have a lot of good genes for overabundance of foods. That's the problem. But fasting, has, affects things. And first of all, the terminology is there's intermittent fasting, which is usually like where you fast for a day or half a day or a few days. And then there's time restricted eating where you don't eat for a certain part of the day. You could do a certain number of hours where you just don't eat. And then there's the fasting mimicking diet, which is you do a 5-day low calorie diet. Usually 1,000 calories day one, I think 700 to 800 calories day 2, 3, 4, and 5. And what this does is that it affects all our organs. It affects the microbiota in our microbiome in a good way. It affects our heart, the myocytes actually in our heart. It can grow better. It affects cancer cells, early cancer cells. We get rid of these early cancer cells. The liver actually can transform certain components into natural signals for the other parts of our body to become more insulin sensitive, and it affects our muscles in a good way. So, fasting, intermittent fasting, or time restricted eating, or fasting mimicking diet is something that we use quite frequently. In fact, I've had some patients that have had abnormal lipids, and I've had them do a fasting mimicking diet for 5 days every month for 3 or 4 months. And I've seen significant improvements in a lot of their lipid biomarkers just by doing that one thing. So it is very effective.
What is your typical prescription with time-restricted feeding?
Well, I think, and I agree with Dr. Longo about this, doing it too long is probably not good. You get some gallbladder sludging. I think 14 hours, at most 16 hours of no eating. And this is more important in women. I usually have women do 14 hours and men do 16 hours if they want to do a little longer, but not more than that. Too long is, again, we always think that more is better, but that's not the case with this.
And to clarify, Dr. Campanile, is that because of the bile impact or estrogen's impact in women on the bile? You don't want to go for too long. Yeah.
Well, we don't know for sure, but we think that's what it is in women.
That's kind of the theory.
It causes sludging of bile, and you can get a higher chance of gallstones. And gallstone, having your gallbladder removed is not a benign thing. We want people to hold on to their gallbladders because you need that.
Of course.
That bile is very important for lipid metabolism. So we don't, and from a cardiology standpoint, we want you to hang on to your gallbladder.
It's a great point there, and nice to make that link because they just come out willy-nilly, it seems.
Yeah. Well, we do a lot of things willy-nilly that later we find out is not the greatest thing in the world.
And can you speak to the importance of nitric oxide in cardiovascular health, and how can we naturally boost it?
Yeah, well, that's a great question because nitric oxide is, I spoke about the endothelium, and the endothelium is that one cell layer, and it's dependent on nitric oxide to be mobile. And so the way this works is that there's certain amino acids like citrulline that can convert to L-arginine. Then L-arginine, there's an enzyme called eNOS, and that converts it into nitric oxide. Then nitric oxide goes into the smooth muscle, and it causes the smooth muscle to be more flexible. Our arteries are not like just tubes; they're active components of our bodies. Very important for high blood pressure management, for blood flow. Like every disease process in our body, including cancer, Alzheimer's disease, they all have a vascular component. So the way the vasculature directs blood or restricts blood is by this endothelial system. So it's very important to know if it's working properly. And then, you can test certain things in the blood, like ADMA, SDMA, and homocysteine. These are biomarkers that sometimes indicate nitric oxide dysfunction. And you can supplement to get that better, but the best way to get that improved is with exercise. Exercise is a really important way to increase nitric oxide. Another way is to use a sauna. A sauna is really helpful for increasing nitric oxide. And in fact, the studies from Finland, because everyone in Finland has a sauna, so they study this quite well there. If you do sauna 3 times a week, 30 to 45 minutes, you can reduce your cardiovascular risk by 30 to 40%. So it's a powerful effect on risk reduction. And or for nitric oxide, you can eat foods that are rich in L-arginine, like beets are very rich in L-arginine, arugula, almonds, these foods. So when we see and we measure endothelial function with we have this simple machinery that can measure endothelial function, and we see good effects when we either supplement directly with nitric oxide or we give indirectly L-arginine or citrulline or foods that have L-arginine. There's all different ways of doing it.
I want to segue into advanced lipid markers. Dr. Campanile, you did speak to apolipoprotein B already, but there are some others that people are not getting on their standard lipid panels. So what do you want listeners out there to know and practitioners to know? What should they be ordering in addition to ApoB? Of course, there's LP(a) you referenced briefly before. Homocysteine is another one that comes to mind for me. SD-LDL or small dense LDL. Can you give us a little kind of quick summary on those advanced markers?
Yeah, sure. I mean, first of all, the reason why we get advanced markers, people say, why don't you just measure, good and bad cholesterol, right? And first of all, I don't like that terminology, good and bad cholesterol. The LDL is bad, and we know that, but there's more bad markers. There's markers that, predict future risk much better than LDL, and that's ApoB. And then there's LP(a), which is a plasminogen-like molecule that's more hereditary than it is secondary to diet, that augments your risk. And so if you have elevated LP(a), it makes us be a little bit more proactive in reducing the other biomarkers that we know make a difference. So, for instance, if you have some degree of coronary disease, we usually want your ApoB to be below 60. But if you have LP(a) elevation, then we really want that to go down to about 40 to offset the added risk of the LP(a). We don't have a medicine yet specifically for LP(a). Now, once you have the ApoB reduced, then you want to know if there's residual risk. And the residual risk comes from the particle sizes of the LDL, the particle number, and also the HDL cholesterol, which we call the good cholesterol. I don't like that terminology because we don't really know if it's good or not. There are people with very high HDL cholesterols that have dysfunctional HDL, and it's actually it's counterproductive. It can go against you, and so you have to know if the HDL is functional or not functional. Now, unfortunately, we don't have a good reverse cholesterol transport test, but we have indirect measures of that. We can measure the type of HDLs you have, the alpha 1 particle. There's 5 different particles in the alpha 1 particle. The bigger and more you have of that, the better. And then there's the lipoprotein A1, which is akin to that. That is very important. The higher you have, for every point you go up in that, you reduce your cardiovascular risk a significant percentage. And what we look at more, if you're going to go one step beyond just looking at ApoB, you look at the ApoB A1 ratio. And that's the capital A1, not small a. It's confusing. Small a is bad, capital A is good. And so that ratio gives us an indication of whether you're prone to grow plaque or you're prone to stabilize or reverse plaque. And the cutoff there is 0.6. If your ApoB capital A1 ratio is 0.6 or greater, then you're probably going to be putting on plaque. But if it's below 0.6, like if you're down to 0.4, then we're seeing a growing number of patients that are having reversal of heart disease. We have now sophisticated ways of looking at arteries, and we can see reversal of disease. And that's really the bottom line. We want to have the soft plaque improve. And that once you have the soft plaque stabilized or improved, then you're reducing the main thing, having a heart attack. Then you're reducing the risk of a heart attack.
Mm-hmm. And so to be clear, just seeing a high LDL on a standard lipid panel, that doesn't stratify risk very much at all. I'm just wondering if someone comes in with that, you're obviously going to want to order these additional markers rather than giving recommendations based off of that really standard lipid panel. And that's what is done every day. Providers are considering statins based on just standard lipid panels. Is that, in your opinion, we just need more information. And you mentioned imaging. We're just looking at labs oftentimes when we're putting folks on medication based on ASCVD calculator risk. I'm just, thinking about how do we stratify risk, and it just doesn't seem to be enough in standard practice typically.
No, and we have technology today that is super helpful. There are 2 technologies. One is a little older, but there's a newer one that we use quite a bit. And a less involved one is called the CT coronary calcium score. And it's helpful. That test is more helpful if it's negative, if it's normal. And if you have, if you're a patient, your LDL is a little high, and let me explain what it is. CT coronary calcium score is it's a CAT scan without contrast, and it can measure with this score, the Atkinson score, how much calcium and where it is in your coronary arteries. So, normal is 0, no calcium. And I see scores from 0 up to 5,000. There's a huge variability. So if I get and young patients, for instance, I get patients in their 30s and 40s that, they have lipid elevations. They don't have a lot of other risk factors. If you do a CT coronary calcium score and it's 0, you can pretty much do lifestyle change, diet, exercise. You don't really have to put them on a statin. On the other hand, if their CT calcium score is elevated, then you have to be a little bit more proactive. Now, what's better test, it's more involved and more expensive, but it's a CCTA, that's called a coronary CTA. It's a CAT scan with contrast where we can see the inside of the artery, we can see how much plaque there is. And then on top of that, there's newer technologies with artificial intelligence, like Clearly is one of the companies that does this. That's CLEERLY, where they have a algorithm with artificial intelligence that can differentiate the plaque into calcified plaque and then 2 forms of non-calcified plaque. A low density one, which is inflamed, and a non-inflamed, non-calcified plaque. And that's very, very important to know about that, where it is, how much there is, and where it is. Where it is in the coronary arteries is very important. If you have plaque, a little bit of plaque downstream in your arteries, that's not as important as plaque upstream, because the upstream plaque can cause serious problems like cardiac sudden death. The downstream ones usually don't do that. So, and then we can follow this over time, and they have great software for comparison, and where you can see with whatever therapies you're doing, lifestyle changes, these sort of things, if they're working. If you do a plaque analysis and then 2 years later you do again, and the plaque has worsened, then you have to be a little bit more aggressive in what you're doing. You got to change your plan. On the other hand, if it's getting better, then you're on the right track. And we have a growing number of patients now with significant reversal of heart disease.
Amazing. And real quick, does insurance cover Clearly at this point?
Well, there's two parts to Clearly. There's the CAT scan portion, and sometimes if you have the right diagnoses, the insurance companies will pay for that. The Clearly portion of it, they're starting just now to start covering it, but for the most part, the Clearly portion of it, the artificial intelligence overread portion of it, is not covered. I think it's usually in about the $700 range, so it's not cheap, but it's such crucial information that it's worth it if you can afford it.
Sure, there's value there. What about AI EKGs? Is AI now interpreting EKGs? What's going on there?
I'm happy you asked that, because it's AI EKGs is really revolutionary. What they've done, what has been done with AI and EKGs is taken EKGs, thousands of them, and put them into a computer, and then you associate different things with those EKGs, whether the patient's male or female, how many chronic diseases they have, whether they've ever developed atrial fibrillation in their life, and then the AI can look at an EKG, and it's pretty amazing. This is things that a cardiologist can't read on an EKG. Only the AI can read it. It can tell you if the patient's male or female, which is,
that's wild.
We didn't know that there was that kind of a difference in EKGs. And it can tell you basically your biological age and it's probably one of the best measures of biological age, because by putting in EKGs with, and teaching the computer that, these EKGs have one chronic disease up to like 10 chronic diseases, it can see where you are on that scale and then determine what your biological age is, how bad those chronic diseases are affecting you. And it's probably the best. We don't have a really good way. Atrial fibrillation is a really serious abnormal heartbeat. It's one of the principal causes of stroke, because blood clots form when you develop atrial fibrillation. So we really want to know when someone develops atrial fibrillation or is prone to develop atrial fibrillation. And AI can predict better than any other test we have if you're going to develop, if you have a high chance of developing atrial fibrillation. So if you do have a high chance, let's say you have the AI saying this patient has a 10, 20, 30, 40, 50% chance of developing atrial fibrillation, then you just monitor that patient very closely to see if they develop. So it's very helpful to finding that arrhythmia early so you can offset the dangerous consequences of it. So
that's so fascinating.
It is fascinating.
Is it just one EKG, or does it require a series that AI needs to interpret at different time points? I'm wondering, it's just one and done snapshot. I mean, if that's your baseline, you're relaxed, you're not on any kind of stimulant before, or, just try to get a baseline for that person. It's just one EKG.
One EKG, but we do, when we see patients, we see EKGs. I mean, we do EKGs all the time. So if, let's say, you do an EKG today and it doesn't have, doesn't see anything, and then you do another one later, and you've developed a chronic disease that's affecting the EKG in a bad way, like lung cancer or something like that, the EKG may be able to pick that up. It says it'll just say that your biological age has diminished for some reason.
Right.
Sort of like I don't know if you've ever done in-body body composition testing.
I haven't done that one in
Yeah,
particular.
not
So in-body composition testing, that's a whole other subject that we use quite a bit. But one of the tests they do on that is called a phase angle. A phase angle is an electrical impedance of the health of the cells. So if the health of your cells is not appropriate, you have a little wrinkly raisin-like cell, the phase angle is down. And it's a very accurate way to measure that. And the EKG is probably picking up on that same sort of electrical activity.
Very cool. I'm so glad I asked, because that was just something that came up very recently. And I thought, wow, I mean, AI is really, you're seeing it in really all these applications. So thank you for that. Super cool.
Yeah, and in cardiology, we're using AI in everything. Echo ultrasounds, cardiac catheterizations, this CAT scan. I mean, we're using it quite a bit, because cardiologists aren't shy to get help. we like the extra help.
Yeah. Of course. Yes, we all do. And we're coming up on the hour, Dr. Campanile. This has been fantastic so far. I'd love to touch on some functional medicine modalities. You mentioned sauna before, but cryotherapy, hyperbaric oxygen therapy, photobiomodulation. Can you speak to how you use some of these therapies for heart disease?
Like I mentioned with, the hyperbaric, these are all modalities that can help vascular health in a big way. Hyperbaric oxygen is, came from in cardiology anyway. I mean, hyperbaric oxygen is used for many different things, but in cardiology, it helps grow more blood vessels. So our bodies have an ability to grow more blood vessels. Like in our heart arteries, we have an ability genetically to develop what's called collateral circulation and small vessels, like natural bypasses. So hyperbaric oxygen enhances this by promoting this ischemic effect. It's sort of like a hermetic ischemic effect. And the way we discovered this is by when we do stenting or we do bypass surgery, we know if we block the artery just temporarily and then let it go, the artery responds better to our modalities. And this is what hyperbaric oxygen is doing, this basically non-invasively. And it it causes things like stem cell stimulation. So it increases the stem cells, your natural stem cells, to go up. And there's been some studies where it improves telomere length, which, telomeres, as you may or may not know, are the little ends of the DNA, and they're like the DNA. If you think about it as a shoe string, like the little plastic ends of the shoestring is a telomere. The longer that is, the longer the DNA lasts. So this is one of the modalities that's been shown to increase telomere length. So it's a very effective way to non-invasively improve blood flow.
Interesting. So it's that little stressor, like you said, that little bit of ischemic impact to get the body to do what we want it to do.
Yeah,
you need a little bit of that stress. That's how exercise works too.
Right. These hermetic effects. That may be how heat therapy works. Like sauna and hot tubs and also exercise, and that's why some people think good stress, like if you can deal with it, is not bad for you. It's good for you. Like you want to be stressed, like at work, you want to be stimulated. You want to be, you don't want to be, just sitting in a chair all day. You want to be stressed in a good way. And that's what this is. We're finding more and more of these things that are, good for us.
And how often should patients be utilizing things like sauna, cryotherapy, or hyperbaric?
Well, hyperbaric, we usually, if we do it, because it's a whole session and it depends on how you do it. There's different ones. There's low atmosphere chambers. They're like bags, basically, that people lie in. Or there's the bigger chambers where you actually sit in. There's TVs and you can sit in there for a long time. And those bigger chambers appear to be better because they can go at higher atmospheres. And that means that the effect of it is better. But usually we do it depending on the disease. If it's just preventative, then you don't have to do it very frequently, once every 2 weeks, that kind of thing. If on the other hand, you are doing it for therapy, you have, high grade blockages, but you don't want to have a stent, you don't want to have bypass surgery, then you may have to do it a little bit more frequently.
Mm.
And then you mentioned, the cryotherapy is another way that reduces inflammatory markers. There's different ways to do the cryotherapy. There's the cryotherapy chambers that you stand up in, which are the real ones. Then you could do like poor man's, like the way I do it.
I was going to ask.
Like cold water or cold shower?
I fill the bathtub up with cold water, put a big bucket of ice in it, and I just lie in the ice for 5 minutes, and ice water, and it's amazing. Theoretically, it's supposed to increase your dopamine levels, and you really feel like you're super vigilant and super alert. But it also has been shown in studies to reduce CRP levels, which are the inflammatory marker. That's a part of the advanced lipid markers we look at is CRP. LDL and ApoB go down, triglycerides go down, and we don't have a lot of good ways to lower triglycerides. And then there's a bunch of markers of plaque instability, and those markers go down. So it's a way to stabilize your plaques. The holy grail of cardiology is what's called a vulnerable plaque, is to identify a plaque in your arteries that can rupture, and if it can rupture, it can give you a heart attack. So things that stabilize a vulnerable plaque is very helpful, and that's what cryotherapy does.
Well, Dr. Campanile, this has been a great episode so far. I'm really
we're just getting warmed up.
I know. I was going to say, I think we could add in like 100 more questions. We could totally keep you for a second hour.
We still have the laser. If you want to give us any information on the laser, the photobiomodulation, I'm curious about that one too.
Yeah.
Well, photobiomodulation is a newer technology with red light therapy, and it's been used in heart failure, studied in heart failure. And the way they've done this is with red light therapy, it's put in the nose because we have this very high level of blood vessels, and
interesting.
It apparently affects the mitochondria in a good way. So by stimulating the blood in your nasal passages, you're increasing stem cells, and they've taken heart failure patients with a reduced number of myocytes, the myocardial cells. After photobiomodulation, the number of cells go up, and which is quite fascinating. The other thing that has a similar effect is rapamycin. Rapamycin is a chemical that also has the same myocyte stimulating effect. So there's a lot of interesting new research coming out on these therapies. The photobiomodulation is red light therapy. So doing good red light therapy is good for you. The way I do it, I don't do this nasal one, but I do the in the sauna. I have a red light therapy panel, and I do it while I do the sauna. So you do the sauna, red light therapy simultaneously. Good thing to do.
There's so much that we can do at home. I love that message to take home with us.
Yeah. I feel like this whole episode has had so many things that people can really take with them, whether they're a provider or a patient listening in that just wants to improve their own cardiac health and prevention and improve their own markers. So I feel like we touched on so many things that are just really helpful. And I'm probably going to go back and re-listen to this episode once we launch it. And I'm really happy that you took the time to be with us today. You're just a wealth of knowledge. We could definitely do a part 2 sometime.
Teaching is a big part of what we do. My wife is a physician. She's a functional psychiatrist. We wrote a book together called the Sicilian Secret Diet Plan. But we have a newsletter, podcast, and we do a lot of this on a regular basis. So if anyone's interested, my website is our practice. We have 2 names, actually. One is Corion, CORAEON.com, or functionalheart.com. Functionalheart, one word.com. So you can connect all these things from there.
Awesome. We'll link these down below for you guys so you can easily connect with Dr. Campanile online. And again, thank you so much for your time today. And until next week, wishing us all vibrant health and wellness. Thank you so much for being here today. Don't forget to leave us a review and subscribe so we can continue to pay it forward together. And remember, the key to longevity is knowledge. Keep learning, growing, and tuning in to the Vibrant Wellness podcast to discover the latest insights and strategies for optimal health. Join us again next week. And just a reminder, this podcast is for educational and informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. The views expressed by guests and hosts are their own and do not necessarily reflect the official policy of Vibrant Wellness. As always, consult your healthcare provider before applying any recommendations that you heard here today.